So our last speaker today, in this morning session, is Dr. Mark Hannibal. And I have to tell you, it has been an unbelievable pleasure. He is our primary geneticist for our immune heme program. And we all just think he's an unbelievable wealth of information. And he actually did his medical school here, right? And then went to University of Washington and did his training in genetics. And when I was talking to our guest speaker last night, he assured me that they really were unbelievably upset when Mark left, because when you're in clinic and you have somebody that you just can't figure out what the heck is going on, you call Mark. And so we have been very lucky, because we have found that exact same thing, that when we can't figure out what's going on, we call Mark. So he's going to talk to us today about unique gene variants in immunohematology.
So welcome to the symposium. I, like Kelly at the beginning of the talk, have a few introductory slides, just trying to tell you what our clinic is about, what kind of patients we see, and then I want to update you on new disorders that we may see. I don't think we've actually come across any yet that we're proving, but I wanted to give you the latest update. So as Kelly said, our immunohematology program is a collaboration between several different disciplines. And I'll have to modify my IgM molecule to the alternate form that includes pharmacy next year. There are, it sometimes forms hexamers. The description of the 200 or more immunodeficiency disorders that are encountered can get quite complex, and people have written textbooks about this. But there's also an international committee that comes up with an update every few years, and one was published last year, and out of the Clinical Immunology Society last year, there was a presentation on an update of these talks, of these conditions. And in a similar vein, I wanted to give you an update from what was published last year in 2014, what's come out in the literature since then. But if you want to get a pretty good comprehensive look at all of the disorders that are seen in immunodeficiency, this is a great source. And it sort of fits into the scope of our framework and what we see in our immunohematology clinic. And these first 6 or 7 disorders are part of that framework that's in the article. We've expanded into a little bit more benign hematology as well. So my talk is organized sort of based on these classes of immune deficiencies, the combined immune deficiencies, those combined immune deficiencies that have more syndromic features to them, not just the immune system. Disorders that are primary antibody deficiencies, problems with the B cells, few disorders where there's just generalized immune dysregulation and a lot of autoimmunity, as well as predisposition towards infections, neutrophil disorders or phagocyte disorders, and then defects in the innate immunity, toll receptors, things like that. But as we've realized, we're seeing a lot more autoinflammatory disorders, complement deficiencies, bone marrow failure disorders, different forms of cytopenias, often with a genetic component, but many are garden variety immune-mediated thrombocytopenia. Proliferative disorders that are non-malignant often come to our clinic, but are managed both by the oncologists as well as the benign hematologists. And then a few of the red cell disorders that fall outside of the scope of Drew Campbell's hematology clinic too. And then there are a few disorders I'll mention at the end that look like primary immune deficiencies, but may not be the result of a germline mutation. They can be a somatic mutation. They can be an aspect of autoimmunity. So my goals today was to give you an update since 2014. We'll start with the combined immune deficiencies. Classic ones are the severe combined immune deficiencies, CD40 ligand, which we had a great presentation at morning report this morning. So one that came out this past year is another nucleotide synthetase disorder that shows the essential role of nucleotide synthesis for the development of effective T and B cell function. And this was the CTP synthase 1 deficiency. Publication came out describing 8 cases from a few families. And they, just like other combined immune deficiencies, have very early onset, a severe viral and encapsulated bacterial infections, variable amounts of lymphocytopenia across these patients that have been described. So some present more like a severe combined immune deficiency, and others are more mild. And then in other pathways, this is the theme. This was a big talk at the meetings over the last few years, is the recognition of the PI phosphatidylinositol 3 kinase pathway. And more members of this family are being linked to germline mutations involved in immune deficiency. So this past year, the P85 regulatory subunit, the alpha form, was identified in several cases. And these are gain of function changes in these genes that lead to enhanced lymphocyte death, and then defects in how the T and B cell pools are maintained in homeostasis, how B cells go about immune globulin switching. Another disorder that is becoming a theme in the last few years is the whole NF-kappa B activation pathway. And there's a couple of disorders I'll describe. There's a recessive disorder where there's a deficiency in BCL10 that's part of the CBM heterotrimer that's involved in NF-kappa B activation. This was identified on the basis of a single case, but that's one of the luxuries that we have in immunology, is that with a single case, we have the accessible cells and we can demonstrate that the defect is there. We can quickly go to functional assays and show that this particular change is responsible for the phenotype. In the case of BCL10 deficiency, they also have early onset of severe recurrent infections, impaired generation of memory T and B cells. And interestingly, there's also probably some defects in the innate immune system. They found some evidence that fibroblast activation defects were also demonstrated, whereas NK cell function was fairly intact. Another NF-kappa B pathway is the NIC deficiency, one of the NF-kappa B inducing kinases, also called mitogen activated protein kinase number 14. It just rolls off your tongue. These individuals, again, 2 cases, siblings, had recurrent severe infections, including infections with cryptosporidium, which can cause a lot of liver disease and pulmonary disease, low immune globulins, B cell lymphocytopenia, impaired memory, B cell differentiation, abnormal NK and T cell function. So in these individuals, they can show that the defects are present in the different cells, and could go down to the level of looking exactly at the kinase where the defect is. Switching gears a little bit, now another pathway, the IL-21 receptor loss of function, has another combined immune deficiency phenotype to it. This is a recessive loss of the receptor, and again, they present with early infections, liver disease, a predisposition towards cryptosporidium infections. People could show that there's impaired STAT phosphorylation, downstream signals, and evidence of T, B, and NK cell dysfunction. In this case, you can see the extensive lung disease. In this picture, and then the ascending cholangitis and abnormal biliary tract in these cases. And this shows cryptosporidium in bronchoalveolar lavage fluid in these individuals. Then I'll talk about a couple of the syndromic combined immune deficiencies. We see a lot of these. 22q11.2 deletion is very common, 1 in 3,000 individuals. Ataxia telangiectasia is another example that we've heard about this morning. So there's an interesting congenital disorder of glycosylation called the phosphoglucomutase 3 deficiency that was identified this year. And it actually came out pretty simultaneously in from three different groups, 15 cases where there's a deficiency in this enzyme. And it's marked by early onset of recurrent infections. They have increased IgE, which we can see in other immune deficiencies, pretty significant dermatitis, autoimmunity, and what makes it syndromic is that there's also developmental delay, intellectual disability that we see in common with other congenital disorders of glycosylation. Some of them had such significant defects that their T cell counts were down in the SCID range. So this came out of 3 different laboratories, 3 different very large groups looking at patients from different areas around the world. Now I'll switch to predominantly antibody defects. We see a lot of this common variable immune deficiency. We're slowly chipping away at all of the germline genetic basis of common variable immune deficiency, and then the classic disorder X-linked agammaglobulinemia. So I mentioned before IL-21 receptor deficiencies showing sort of a combined immune deficiency. Well, IL-21 deficiency was identified this year as well in 3 cases. It appears, at least from these initial reports, that it's a fairly narrow B cell abnormality, and like many other B cell disorders, presenting with bowel disease. This may be a little bit earlier than other ones, so I worry a little bit about maybe there is a combined component and more T cell dysfunction than we're led to believe. But they get recurrent infections and they develop low immunoglobulins. So we're seeing more and more patients for very early onset inflammatory bowel disease in our clinic, and we'll hear more about that today as well. This was a short, interesting case report, one case. So there's a whole field of congenital diarrheas that we see in individuals. And the causes of these are slowly being identified too. We've actually had a patient with this disorder seen by one of my fellow geneticists. But what struck me about this report is that it was a patient who had evidence of trichohepatoenteric syndrome, but didn't have the constant diarrhea that is usually associated with it. Had a couple bouts, but was living up until 7 or 8 years of age, doing fairly well. But they could show that this patient had an abnormal immune system, had recurrent infections, and could demonstrate had a very poor antibody response to immunization with impaired memory, but yet didn't have the enteric phenotype that most cases do. Then there are disorders of immune dysregulation, the familial hemophagocytic lymphohistiocytosis that we're now recognizing not only has specific genes related to perforin and other granzyme function, but also can be triggered by metabolic disorders and other conditions, the X-linked lymphoproliferative syndromes. There's a few new disorders that have been described with this. One of them was gain of function in one of the inflammasome components, NLRC4, that leads to autoinflammation and, again, early onset enteropathy. 4 cases have been described. These are really struck by having pretty significant fevers and immune activation and development of hemophagocytic lymphohistiocytosis like phenotype from a very early age in infancy. And this came out of two separate reports. One group out of Yale describes a case that they identified because it didn't fit classic phenotypes, and they did exome sequencing. One of the most interesting disorders that I've seen come out this year is another STAT gain of function defect, and this involves STAT3. We know that STAT1 and STAT5B are involved in immune deficiencies, and now 18 cases from three different reports, or two different reports, have identified the STAT3 gain in function with early onset autoimmunity, type 1 diabetes, enteropathy, cytopenias, in many ways an almost IPEX-like autoimmune predisposition with immune deficiency. And you can see here, looking at STAT activity with the people with the defect, they have very high constitutive level activation of STAT with these defects. Another gene that's involved in putting the brakes on our immune system, CTLA4, the protein that counteracts CD28 co-stimulation in T cells, was identified as being linked to a autoimmune phenotype, and in this case is just simply having haploinsufficiency. So it's not a gain of function, but losing half of the normal amount that you have can lead to immune dysregulation, where we see thrombocytopenia, enteropathy, a tendency for lymphoproliferation, as well as evidence of an immune deficiency. There are 17 cases reported in that, so it may be something that becomes more common. There are defects in phagocyte number. Classic one is Elaine deficiency for one of the most common forms of severe congenital neutropenia or cyclic neutropenia, and then with function, chronic granulomatous disease. So there is another form of severe congenital neutropenia that actually has a fair number of cases already described, and it will be interesting to see if this becomes one of the more common ones after Elaine mutations. It's a recessive condition with the deficiency in JAG-N1, and the report showed a very nice maturational arrest of the granulocytes, evidence of endoplasmic reticulum stress and impaired glycosylation. So JAG-N1 is expressed in the early part of endoplasmic reticulum processing of different proteins, and they showed very nice information on the various glycan structures of proteins coming out of the ER, and showing the differences in the patients where there is altered glycosylation. The other defects that we see, defects in the innate immunity, autoinflammatory disorders. I didn't come across any specific conditions. The complement deficiencies, bone marrow failure disorders. I think Fanconi anemia, dyskeratosis congenita is something we're seeing quite a bit of and making new diagnoses, but there hasn't been a new gene identified for these recently. In acute and chronic cytopenias, Evans syndrome sort of overlaps with what we know about lymphoproliferative syndromes like ALPS. There was a description of a novel gene association with defects in tripeptidyl peptidase 2, causing early onset Evans syndrome, very early in infancy, lymphoproliferation, infection susceptibility, and they could demonstrate defects in premature senescence and loss of B and T cells, as well as in fibroblasts. Another more straightforward, just thrombocytopenia defect was identified in a transcription factor, the ETS variant 6 gene, and in several families identifying probably haploinsufficiency with this gene. In 10 cases causes child onset thrombocytopenia, and then an increased risk for various kinds of hematologic malignancies. This came out. There's some data from these pedigrees that there's an increased risk of hematologic malignancies as well as a few solid tumors. Most of the solid tumors, though, have been basal cell carcinoma, and it's really unclear what that risk is, and I think bears identifying more kindreds. There's other proliferative disorders that we see in clinic, Langerhans histiocytosis. We've had an interesting case this year of hypereosinophilic syndrome, red blood cell defects we also see in our clinic. And then the phenocopies of primary immune deficiencies are the ones that have somatically acquired mutations in genes, such as the form of ALPS that's due to somatic FAS mutation, or some individuals who have chronic mucocutaneous candidiasis because of autoantibodies to IL-17 resulting in activation or deficiency of IL-17, like we can see in genetic defects, but it's just due to autoantibodies. So how are we making diagnosis in our clinic? With these ever-increasing numbers of genetic disorders, it makes it very difficult, and trying to do anything gene by gene. Each gene that we're sequencing can cost $500 to a few $1,000s. So if we're very sure of a phenotype, we can do targeted sequencing, but more and more we're turning to next generation sequencing panels or even exome sequencing as tools. We have a good network of research collaborators that we also rely on, particularly when we can't get clinical testing because of insurance issues. And I think there's other prospects out there that are going to help us. Genomic sequencing looks like, in general, with exome sequencing, we can make a diagnosis 30 to 40% of the time. In patients that come through our genetics clinic, with genomic sequencing, the data out there is it's more sensitive, maybe 40 to 60% of the time. We'll be able to find a responsible defect. So I just wanted to thank and acknowledge Dr. Picard, who gave this talk at the Clinical Immunology Society meeting last year, and I'll take any questions that you might have.
Dr. Mooney?
Very nice summary. We have a couple of patients with George and Evans. Anything in that whole region, any particular gene or anything specific?
So Rajan had a question. They have a few patients with DeGeorge 22q11.2 deletion syndrome and Evans syndrome. Is there any particular candidate gene on the 3 million base pair region, 20, 30 genes in the area that are commonly deleted that suggest a candidate? And I don't know that there is a particular one, but whether it's a innate thymic defect that predisposes to them. ITP is one of the more common autoimmune manifestations in 22q deletion, happening in about 5% of the individuals.
In the familial thrombocytopenia syndrome you described towards the end, do you have a feel for what the depth of the thrombocytopenia is in those patients and what the interval is between, I guess, diagnosis of the condition and the occurrence of the malignancy, let's say leukemia?
No, I don't know that with the ETV6. I don't know those details.
All right, thank you very much. I think with that, we will we'll take a short break.